Okay, guys, so we are going to discuss the another station of the critical care, the obstructive jaundice. So, a 50 years old male admitted to hospital with epigastric pain, nausea, vomiting, diarrhea. His lab showed increased ALT, AST, ALP, GGT, PT, and CT. Urobilinogen is undetectable in urine. You will be wondering what is CT. CT is clotting time, basically. So, a 45-year-old female patient complaining of 2-day history of epigastric pain, nausea, vomiting, diarrhea. She has dark urine. Clinically, she is jaundice and has mild epigastric tenderness. Labs showed increased level of ALT, AST, ALP, GGT, and urobilinogen undetectable in urine. Normal bilirubin level is 3 to 30 micromole per liter. Apparent jaundice greater than 35 micromole per liter. So this lady seems to have obstructive jaundice. So the second scenario is very clear, I think, but in the first scenario they haven't mentioned about the jaundice, but I think it's misworded, and there will be always like a proper scenario. So what is the type of jaundice from the blood test? It's obstructive or post-hepatic jaundice. Why is clotting deranged? Liver synthesizes most of the clotting factors. In severe liver damage and biliary obstruction, there will be decreased absorption of vitamin K. Vitamin K is required to activate factors 2, 7, 9, 10, 1972. So 1 is your 10 actually. So factor 10, 9, 7, and 2. There is another mnemonic which is 1973. What is this? So this is those nerves, cranial nerves, which are parasympathetic. So 1973 is basically your cranial nerve 10 and cranial nerve 10 and the other one 7 third, because it's 73, and ninth. So these are your parasympathetic nerves. Okay, so coming to the topic, which clotting disease may be abnormal. This will lead to increased prothrombin time or INR. So PT is basically deranged in liver disease, because remember the mnemonic wept. So W is warfarin and wept, EPT. So E is your extrinsic pathway and PT is your PT. So warfarin, extrinsic pathway, PT, liver diseases, vitamin K deficiency, these all interconnected. How to correct clotting abnormality? IV vitamin K 10 milligram once daily for 3 consecutive days, and fresh frozen plasma for rapid correction. Prothrombin complexes concentrate. Consult hematologist. Prothrombin complex, human prothrombin complexes or concentrates are better than FFPs. What is alkaline phosphatase? Where it is formed? Enzymes, which are enzymes. Okay, enzyme located in the epithelium of bile canaliculi. So this is basically a bile canaliculi enzyme present also in bone and placental tissue, increasing cholestasis to a far greater extent than LT-AST. So when there is obstructive picture, there will be raised alkaline phosphatase. ALT-AST present in hepatocytes, and their increase is suggestive for limit damage. Hepatocyte damage is shown by ALT-AST. ALT in the viral, AST is in alcoholic. Rather than obstructive jaundice, ALT is greater than AST in liver pathology. Other investigation you want to do abdominal ultrasound. So whenever there is a patient with obstructive jaundice, you start from like the blood investigation are very basic. You will do these. So there will be conjugated bilirubin, or like, yes, conjugated or total bilirubinemia. Bilirubin will be high, and you start from ultrasound. Always you start from ultrasound and then you go further. Like if there is weight loss, you can do CT for pancreatic cancers, and you can do endoscopic ultrasound as well, check biopsy and so on. So, what findings on abdominal ultrasound will confirm diagnosis of obstructive jaundice? Dilatation of intra-extrahepatic bile ducts. If you find a CBD stone, ERCP, go for ERCP always. What is the function of bile? Emulsification of it into micelles thus provides a greater increased surface area for the action of pancreatic lipase. Yes. How do bile salts help in emulsification of it? What is the physiological role of bile salts and how does it achieve its function? Bile salts anions are hydrophilic on one side and hydrophobic on the other side. Consequently, they tend to aggregate around the droplets of lipids, triglycerides and phospholipids to form micelles, with the hydrophobic sides out towards the fat and hydrophilic sides are facing outwards. The hydrophilic sides are negatively charged and thus char prevents fat droplets coated with bile from re-aggregating into larger fat particles. So they prevent re-aggregation of fat particles and they form micelles. So there is a high chance for lipases to act on because they have great surface area. What are the constituents of bile? So bile contains of water, cholesterol, lecithin, a phospholipid, bile pigments, biliverdin, bile salts and bile acids, sodium glycolate or chelate, sodium taurocholate, some small amount of copper and other extreme metals. So bile is basically you can see the diagram. In the diagram we have the bile 97% water and solids 2.4%. So organic substances, inorganic substances, sodium, calcium, potassium, chloride, bicarbonate, bile salts, bile pigment, cholesterol, fatty acid, lecithin, mucin. What is bilirubin conjugated to? In the liver conjugates with glucuronic acid by the enzyme glucuronide transferase. So bilirubin is conjugated to glucuronic acid through glucuronide transferase enzyme. How is bilirubin metabolized? So how is bilirubin metabolized? So conjugated bilirubin goes into bile and thus out into the small intestine too. Most bile acid is reabsorbed in the terminal ileum to participate in enterohepatic circulation. Conjugated bilirubin is not absorbed and instead passes into the colon. So conjugated bilirubin passes into the colon. Okay. So their colonic bacteria could deconjugate and metabolize the bilirubin into colorless urobilinogen, which can be oxidized to form stercobilin. This gives stool its characteristic brown color. 10% of the urobilinogen is reabsorbed into enterohepatic circulation to be excreted in the bile. Some of this is instead processed by the kidney, coloring the urine, which is in the form of urobilinogen. Okay, so yes. What is urobilinogen? How it is formed? How to they circulate? It's a byproduct of bilirubin metabolism formed in the intestine by the gut flora or bacteria. Some are excreted in the feces after oxidation, stercobilinogen or stercobilin, and some are reabsorbed into the portal circulation again. Some of this reabsorbed urobilinogen is again excreted by the liver, but small amounts enter the systemic circulation and excreted in urine, also giving the urine its characteristic color. Enterohepatic circulation, reabsorption of bile salt in the terminal ileum and return back to the liver. And remember, if this complication of reduction of bile salts in small intestine, steatorrhea due to malabsorption of fat, poor absorption of fat soluble vitamins, vitamin A, D, E, and K, coagulopathy due to reduced synthesis of vitamin K dependent causing factors. Okay, so here I should tell you from this question, I will tell you some other point as well. If you do resection of terminal ileum, what will happen? Tell me. So if you do the resection of terminal ileum, there will be reduced the enterohepatic circulation of the bile salts. So bile salts help in the solubilization of cholesterol. So if there is less bile salts, because liver take time to regenerate it. So if there is no enterohepatic circulation, no ready-made bile salts, so what will happen? Cholesterol will crystallize and nucleate into cholesterol crystals, and this can lead into cholesterol gallstone formation. If the patient had fever, pain, and chills, ascending cholecystitis, this charcoal tried, and jaundice as well. How can you treat ascending cholangitis? I will manage sepsis by sepsis 6 bundle, boil drainage and relieve the obstruction, ERCP with endoscopic sphincterotomy and stone extraction. If fail, PTC, percutaneous transhepatic cholangiography and this cholangiopancreatography. This is actually the investigation, and there is also an intervention which is percutaneous hepatic this biliary drainage, PTBD. So basically this is one thing, but you can take picture as well, so it will be investigation, and you can do the drainage, so it will be the intervention procedure. So what is sepsis 6? How to treat? I will manage according to CRISP protocol, administer high flux. Remember, there are 6 steps. Give 3 to patient, take 3 from patient. So give him antibiotics, give him fluids, give him high flow oxygen, take 3 from him. ABGs, take ABGs from him, take blood culture from him, take urine culture from him. Don't take anything else. Administer, so this is done. Cause of silent obstructive jaundice. So silent obstructive jaundice, which is painless, this can be CA pancreas. If you find a CBD stone, what to do? Endoscopic sphincterotomy, you go for ERCP immediately. After stabilizing the patient, give him vitamin K, give him FFPs, check the PTNR, and then go for endoscopic. If endoscopic is failed, then you can go for laparoscopic open. Open or laparoscopy, but laparoscopy is the gold standard laparoscopic choledochostomy. So endoscopic sphincterotomy bile duct clearance before or after laparoscopic cholecystectomy, two-stage procedure. Endoscopic stone extraction with laparoscopic cholecystectomy, one-step procedure. And open transcystic CBD exploration can also be done and clearance if failed choledochotomy and biliary stent for biliary drainage. Yes. What are the mechanism behind different types of jaundice? So prehepatic, so there are 3. Okay, let me draw the diagram. This is very interesting. So let's suppose this is your liver. This is the draining process. So it can be prehepatic here. So here we have the red blood cells. So red blood cell hemolysis will cause increased bilirubin, increased jaundice. It can occur in hepatic. So this will be conjugated bilirubin. Conjugated bilirubin will go high. It can be here post-hepatic. So this also conjugated bilirubin. So prehepatic, unconjugated, conjugated, and conjugated. So increased hemolysis and conjugated bilirubin more the ability the liver to conjugate. Insoluble bilirubin does not enter the urine. Normal urine color stool is darkened by increased amount of bilirubin excreted through the liver. Unconjugated is insoluble, so it will not affect the urine. Okay, hepatic, impaired conjugated is soluble in water, so it can affect the urine, darker color urine. Impaired cellular uptake, defective conjugation, abnormal secretion of bilirubin by the liver cells. This can occur in hepatitis C, V, HP, V virus, both. It can cause both unconjugated and conjugated, but mostly conjugated. Okay, decreased excretion due to mechanical obstruction due to the flow, increased conjugated bilirubin in blood, kidney, and excreted in urine, dark color urine, tricolor urine, no circumambulation stool, offensive and pale stool. You will have white stools, which is sticks to the flesh. Conjugated bilirubin deposited in skin, itching, pruritus. Impaired C fibers, it stimulates the C fibers. Impaired fat digestion, stool get pasted in the commode, as I said. So my video is getting bigger. Okay, so what are the causes of jaundice? So as I said, it can be prehepatic, hepatic, and posthepatic. What are the differences between different types of jaundice? So okay, so quickly go through this. In prehepatic, urine color will be normal. Why? Because the unconjugated bilirubin is insoluble in water, and in these two there will be high or like dark color urine.